Alrighty, hi everybody. Can you guys hear me?
Yeah.
Alright, great to see you for our last Hope session. Today I'm excited. We've got our own Samantha Vernon from Centennial AHEC that's going to be leading this session on community health with all of you guys. And she has been coordinating the activities for Hope Centennial. So she's been around and kind of she's been here. So I think I'm just going to hand it off to Sam. Although I will say, pay attention. We're going to talk about Hope Institute, which is our summer camp at the end of that session. So don't disappear. That's going to be some good info. All right. Sam, you ready to go?
Yep. Right. Thank you, Matt. All right. It's pinned up. So like Matt said, I've been with Centennial AHEC for a couple of years now. I've been the coordinator for Hope here, and I am very passionate about community health and very excited to share it with all of you today. So, this for us. 1 second. Gotta run a couple screens over here. So now we're ready. So community health. What is community health? So we're going to talk about that today, and through 6 different ways. We want to identify the types of communities, explore the root causes of health needs, and learn how to create SMART goals, evaluate existing community programs, discuss the power of collaboration, and apply this process in small groups. So community health is a collaborative effort using public health knowledge and evidence to engage and work with communities in a culturally appropriate manner to optimize the health and quality of life for all persons. This is the CDC explanation of what community health is. For me, it's a little wordy, so I'll give you another one. It's examining how the way we work, live, learn, and play impacts our health. And so we're going to watch a short 4-minute video that the CDC also created about how communities throughout the nation have used these 4 aspects to examine health in their communities. Okay, you guys hear?
No, we're not hearing.
Development at its
in order to hear videos. Oh, we hear them now.
All these healthy initiatives are really economic development at its core. So we have customers who are buying these healthy options. We have a business owner who's making more money. And as a community, we're benefiting too because we have a healthier workforce, fewer sick days, less absenteeism, more productivity. I can't think of another thing that we could be doing that's more important.
So this is an opportunity to really think our cities through again. The healthy lifestyles are the #1 ambition. We really are about the people in the neighborhoods, not so much about the streets and the automobiles.
We have implemented a tobacco-free environment at Capital Metro, and it has proven to be a huge benefit and actually something that's been very popular with our passengers and the community in general.
The Community Asthma Initiative is a program that addresses asthma disparities in Boston. What's really remarkable is that we've had an 80% reduction in the need for hospitalizations for children and 60% reduction in children with any emergency department visits.
Diabetes was really a closeted issue. Today, it's really a community conversation. We've reduced amputations by 50%. That translates into a cost savings of about $2 million per year.
We work with Pacific Islander and Southeast Asian women around breast and cervical cancer. After our program, 70% of the women got screened, and they get screened regularly on an annual basis.
When this information came out that this might be the first generation that will have a lower life expectancy than their parents, we decided that's unacceptable for us as Cherokees.
Bronx Health piloted an initiative in a number of Bronx schools to start offering low-fat, no-fat milk. The Office of School Food decided to do it system-wide.
Healthy students equals successful students. If they are eating right, if they're physically active, they're going to do better in school, they're going to score better on tests. Research has shown that over and over.
All the little changes, all the little steps you can take along the way provide a healthier and safer place for people to live and work.
We sell twice as much produce a week than we ever have.
O sea, en los fines de semana. Antes tenía como unos 200 clientes, ahora tengo 500 clientes.
10 businesses in our downtown, which are small businesses who wouldn't ordinarily implement a wellness program, now have set goals and made changes around smoking cessation and exercise and nutrition.
I think our employees understand that we are interested in a holistic, healthy lifestyle, and the policies that we put in place encourage that.
If a downtown is healthy, if the employees that work there are healthy and the residents are healthy, then more people will want to live there, work there, and play there.
We're working with the Parks Department, and we have these free Fitness in the Parks classes that the community has really embraced.
The response to bike share in San Antonio has been phenomenal. It's exceeded our expectations.
Everywhere where we have said no to secondhand smoke, where we have said no to smoking, they are overflowing with people who are spending money, who are enjoying life and enjoying the various amenities that we have for them.
Yes, it's wonderful that it has helped us market our properties more successfully, but healthier residents as part of our communities. That's the real benefit here.
Across the country, folks could use these ideas in their own community and see how making folks healthier really helps community and economic development.
Awesome. So something you're gonna learn about me throughout the evening is that as much as I love to talk, I love to hear from you more. So what do y'all think about the video? I want to hear some thoughts. What's something that stood out and why was it impactful?
I just like how in 4 minutes they when like somebody associates health, we always think of like hospitals and stuff like that. They associated it around the community and what you can do differently in different aspects to help your community and health.
Oh, awesome, thank you.
I noticed that like in a lot of the jump of people when they implement like no tobacco areas, like the numbers of people went up a lot compared to how
Yeah. It really shows you the impact that community health is able to make and focusing on it together as a group. What about our online friends or our virtual friends?
Yeah, I agree. I thought it was interesting that in the video, they directly stated and really like emphasized that it's good for the community as well as the individuals in the community. Like it's important for like the business, but also the people going to the business and living a healthier life. I thought that was interesting.
Right.
I like how it impacted different things. This is Pam on the phone, but different things like the diabetes and the kids and how they addressed other things, not just the health, but the health promotion of like the grocery stores and buying produce and that kind of stuff. That's really holistic and super cool.
Awesome, thank you. All right, any others? All right, yeah, no, I really love this video. I think it does a really good job of showing how diverse working in community health can be. It's something that everyone can get involved in, and it doesn't have to be a project that's super complex or takes a long time. There are projects like that, but it can be something just as simple as making little changes. So. Perfect. Now that we know what community health is, let's talk about what community is. So oftentimes when we talk about what a community is, it's described in 3 different ways. The first and probably the most common is based off location. It's geographical communities. This might be populations based on where you live statewide, nationwide. This might just be where your neighborhood is, what city you're in, whether you're rural or you're urban. And then another way to describe a community is through attributes. So this might be shared race, shared age, shared gender, shared level of income. And then finally, community types based on activities. So this is your interests, like maybe you are on the same sports team together, you're in the same class, you have the same type of job or similar hobbies or interests. And so one thing I want to point out though is that as many ways as there is to describe a community, oftentimes when we're talking about communities that we work with, they're not defined by just one thing. They're a complex mesh of multiple aspects. So for an example, we'll talk about you guys, our Hope students. You guys share a lot of aspects that make you a community of Hope students. You have location, you're all Colorado residents, right? You have shared attributes, you're all high school students. And shared activities, you're all interested in health careers, right? That's why you're here. And so I know sometimes it's really hard to come in the evening and have a long class. So we're gonna start with an activity to kind of wake you up a little bit. This is gonna be just a quick competition activity. I want everyone to pair up and we're gonna give you 2 minutes. And in those 2 minutes, I want you to try to charade as many different communities as you can and you're gonna switch between partners and you're gonna try to guess, okay? And we're gonna see who can get the most in those 2 minutes.
Are you gonna leave that up?
Yeah, I'll leave this up to give you guys some ideas. And those who are joining us online from home, go ahead and just shoot into the chat some communities that you can think of. And I'll give you guys a quick second to get into groups. I encourage you guys, this is about movement. Stand up, get into it. I want to get that blood flowing, get those brain juices going.
All right, so we're to charade to you. Are we charading to other partners or
to each other? Okay, yeah. With your partner, you're gonna take turns doing charade.
Okay.
Is anyone confused about the directions? Ready to go?
Don't take the seat that I do.
All right, your time starts now.
Look up there. Yeah, there you go. There you go. Okay, go. So. School. No.
Oh, but not that.
Age. Ready? Yeah. Things up there. Sports. There you go. Yeah.
Is that? Oh. You know where?
Okay.
Driving.
Job.
Going the speed limit. Scooter. Moped. Income. University. Going.
Race. Sorry, I was thinking.
Okay. Well, we haven't done this before. Yes.
How would you describe class? Would that be like social class or like activities like this?
Mountain.
So on here, yeah. So the way class is on here, it's like say an activity like this one. It's a group where you're like a learning class.
All right.
Oh.
That's not a lot.
All right, time's up. Go ahead and take your seat.
Okay, the person was 8. Because I know. I was trying to say house.
right, just a quick shout out. How many did you guys get? 8. Anyone be 8?
We got 9.
9. Dang it. What about from our other sites? Anyone beat 9? All right, real quick, we're gonna look in the chat, see what our online. Church is definitely a community. Swim team, book groups, neighborhoods. Awesome, thank you guys for participating with that. Hope that woke you guys up a little bit and you guys are ready to keep moving. So once we know what community we're working with, it's important that we determine what their needs are and that we're really hearing their voice and having them impact the work that we're going to do. And I like to refer to what's called the iceberg model. So oftentimes with icebergs, there's what you see is only a very small portion of what is there or is what is going on. So with icebergs, with behavior, with needs, you have actions and behaviors and outcomes that you're able to see. But then you have things like habits, beliefs, experiences, attitudes, emotions, expectations. These are things that we don't always see on the surface that's going on with an individual or with a community that can explain why those actions, behaviors, and outcomes are being seen. And so when we talk about the needs of a community, we really need to be making sure that we're digging deep and finding what those underlying needs are that are explaining what we're seeing. So a really good example of this that I want to do with you guys is a poem that I found online. I think it's really indicative of what we're talking about. Do I have a volunteer who would like to read this for us? Anybody? All right, y'all are trying to make me lose my voice by the end of the night. That's fine. I'll do it for you. So it says, why is Jason in the hospital? Because he has a bad infection in his leg. But why does he have an infection? Because he has a cut on his leg and it got infected. But why does he have a cut on his leg? Because he was playing in the junkyard next to his apartment. Oh no. Building, and there was some sharp, jagged steel there that he fell on. But why was he playing in a junkyard? Because his neighborhood is run down, a lot of kids play there, and there's no one to supervise them. Why does he live in that neighborhood? Because his parents can't afford a nicer place to live. But why can't his parents afford a nicer place to live? Because his dad is unemployed and his mom is sick. But why is his dad unemployed? Because he doesn't have much education and he can't find a job. But why? So this really is what we do in community health when we're looking at what the needs are of the community. We ask why. Why is this happening? So in this poem, I want you guys to shout out, what do you see is the obvious need? What's the need that we can see right away when we talk about Jason?
An infection?
An infection, right? He's got a wound on his leg that got infected. That's a very obvious and immediate need. What are maybe some of the needs that might go unnoticed? If you were just to talk to Jason and see the wound on his leg, what are some of these needs here that you might not know just from seeing him and seeing his wound?
He probably doesn't live in the best neighborhood.
Right? Anything else?
Maybe food insecurity.
Awesome. So another point here that I want to make is that every need is important to recognize. If we just ignored the wound and said, we're going to fix your neighborhood so it's not so dangerous anymore, he's still got an infection. That's really dangerous, right? But if all we do is we take care of this infection, we heal up his leg, but we don't do anything about this dangerous junkyard, then we're not preventing it from happening again or to someone else, right? So when we talk about community needs and community health, we want to make sure that we're working on multiple levels, right? And that brings us to our next slide. Has anyone seen one of these models before? Do you know what this is? This is called an ecological model, and it's something that we use in public health all the time. And we use it to kind of help explain this concept of how health is influenced on every level of community and relationships. So in the center, we have the individual. So we have things like knowledge, behavior, skills. This is where we would put Jason in, right? This is what Jason's behavior is, what his knowledge is. And then beyond that, we have the interpersonal. This is your social network. This is your family and your friends, your neighbors, your teachers. So in our example, this would be maybe in that poem, the concept of how they had no supervision while they were playing. This would be the role of your interpersonal, right? Then organizational and community. This is the places, right? This is where you go to school, where you do your grocery shopping, the neighborhood that you live in. So this organizational and community would be the junkyard, right? Living in a neighborhood that's not completely safe. And then finally, the outer layer is the public policy. This is the state laws and regulations, local laws and regulations. This isn't alluded to in the poem, but we can allude to it ourselves and say that maybe this is the safety regulations for that area, that junkyard. Maybe it doesn't have the best safety regulations, or maybe it's the way that local laws determine funding. Maybe the funding is not going quite the right place, so they can't use it to clean up this area, right? So once we know a need, we're going to try to come up with solutions to address that need, right? And the way that we're going to do that is with something called SMART goals. Raise your hand if you've heard of SMART goals. Awesome, everyone. So I'm going to pick on someone online. Can any of you tell me what the SMART goals stand for? What any of the letters stand for?
I believe the R is relevant, right?
Yes. I did give you the answer, so you're welcome to use those too.
I think they can.
Yeah. I'm telling you, I just want to hear your voices. I don't like talking to myself. But thank you for jumping in there. So as we can see, the SMART goal stands for specific, measurable, attainable, relevant, and time-bound. And it's important that we try to incorporate as many of these as we can to make them the strongest goals possible. So for specific, this is what do you want to happen? You want a clear vision of what's going to change. Measurable is knowing how we're going to tell when it has. We want to see our success, right? Attainable, is the goal realistic? Sometimes not everything we want to get done is possible to get done. We have to take into mind what our resources and our time are. And so we want to make sure that the goals that we're setting are things that we can really make happen. Relevant, why is this goal important, right? And this is an aspect where I really want to stress the importance of data. When we have statistics, and what I want to introduce you to guys is evidence-based research and practice. This means that there has been people who have already tested this and made sure it works. So when we have these statistics and we have this evidence-based research that we use when we create our goals, it makes them stronger. It makes them reliable. And then time-bound. We're not going to work on this for the rest of our lives. We have too many things to do. We want to give ourselves a timeline, all right? So really quick, we're gonna go through a organization that has a advertisement that they put out for their program, and we're gonna see if we can spot these different aspects that we talked about, okay? Okay. All right, so this is a organization called Classroom Wise, and they do mental health training for teachers. And so really quick, we're gonna breeze through it. We're together and find the different aspects of what we've talked about. So the first thing we talked about today is community, right? Determining who the community is that we want to target and work with. So in the classroom-wise thing that we see here, as we read through it, we see that the community that they're targeting are the educators, the teachers, right? And what is the need that they recognized within teachers? As we continue reading, we can see that it's teaching them how to support students experiencing adversity, distress, and mental health challenges in the classroom, right? So this is the need that they identify that they want to work on. And so now we have to look at their goals on how they wish to do that. So their specific goal is creating safe and supportive classrooms, right? And then they measure that through module quizzes. They made sure it was relevant by using evidence-based practice, right? They found other ways that people have done this and they mimicked it or they used it to inform what they created. And then they made it time-bound, right? The completion of this goal will occur by the end of the module. So by the end of this module, the community that you targeted, which is the teachers, are going to know how to create a safe and supportive classroom to support the mental health of their students, right? So now what I want to do is I want to give you guys practice with this, with identifying these pieces, okay? So we're going to have you split into groups. Let's do 3 to 5 students. And actually, let's go with 3. There's a good number of you. We'll do 3 students for this activity, and you're going to use the Safe Teen handout that you received and do exactly what we just did here, right? You're gonna find the community that it's targeting. You're gonna find the need that was identified. No. And then you're going to find the aspects of SMART goals with how they outlined their program, right? Does anyone have any questions?
Sorry. Let me look at my email.
Sam, online looks like we've got 7.
7? Go ahead and create a group of 4 and a group of 3, I think.
Okay.
Yeah, so our online friends are gonna split into breakout rooms to do this activity. I'm gonna give you 5 to 10 minutes. We'll see how much time we need, and then we'll come back together and talk about it.
All right, online friends, I'm sending you to your breakouts.
Community group? Or look at this.
Let's keep it to smaller groups. Let's do 3, 4 max. So I don't know if someone from here wants to join these guys.
Sick.
Three in this.
And also,
We have extras.
yeah, that's it.
I think it, yeah, I think it's just
We understand.
I was looking about
Are they talking yet?
All right. So everyone, give me a thumbs up if you're ready to go. Thumbs up. Awesome. Matt, you want to go ahead and bring back our friends in breakout rooms?
It gives them a 10-second countdown.
Yeah, no problem.
Alrighty, I think we got everybody back.
All right, now that we got everyone back, I want to hear from you guys. What are some of the things you found? Let's start first with the community. What is the community that is focused on in this pamphlet?
Teams.
Teams. Awesome.
Maybe students as well.
Right, students. So.
The youth ages 12 to 18.
Yeah, right. So teens is definitely students, but they're very, very specific in the group they're trying to reach, right? They want teens 12 to 18, which is teens, but there's power in being this specific, right? All right, so what about the need? What's the need that they found?
That 1 in 6 students will consider suicide.
Right, right. So based on that fact, what would you say the need is?
That people need mental health, specifically teens.
Right, right. We need mental health support, specifically suicide prevention support for teens. right? All right, so for our SMART goals, what are some of the SMART objectives or goals that they show in their flyer here? Let's get someone from online. What's one of the aspects of SMART goals that you see in their flyer?
Creation of suicide prevention education.
Yeah, good.
Along those same lines, finding the right resources and figuring out how to ask for those resources.
Right. Good, thank you. So yeah, the education and the resources. So having the resources and the knowledge to recognize warning signs, asking and giving help, and using resources, right?
I don't know what the measurable is, do you? How are they gonna measure?
I don't, they have the time in 60 to 90 minutes.
That's true. That could be, sorry, Sam. Sorry, Sam, we were talking through the measurable.
No, thank you. I'm glad that you pointed that out. So they mentioned just now the time bound. So 60 to 90 minutes. They want these teens to understand these concepts within an hour to an hour and a half, right? But I like that you pointed out that it's hard to find any measurable here. And I will say that there isn't an obvious measurable here. It's not listed. Unfortunately, not always are they going to list every aspect, especially in their flyers. But I will say that we do know the people who run these, and they have they do have measurable ways that they methods. That's the word I was looking for. They have methods to measure the impacts that they're having in the number of students that they're reaching out to. Was there someone here that had a comment?
Oh, I did, but you answered it.
Oh, perfect. All right, so anything else? We got the 60. So the 1 to 6 students will consider suicide. I'd almost say that kind of goes to relevant because they're showing statistics that show how important that need is, right?
At the bottom of the page, it also says programming is standardized, evidence-based, and provided by a certified and experienced trainer. So that's just making sure that it's relevant.
Yes, thank you so much for pointing that out. I forgot to box that one as well. This is definitely not a comprehensive boxing of everything. There's probably more in there. And so I'm so glad that you pointed that out. This is a evidence-based program. So it is tried and true methods, right? So real quick before we move on, does anybody have any questions about what we've covered so far? Questions about community needs, SMART goals? Awesome, you guys are making me feel like such an accomplished teacher. I appreciate that. All right, so we shall move on. So we actually have a really awesome opportunity for you guys to hear from Dr. Bruce Cooper. He is a member of our board here at KHEC, and he has worked as a family medicine doctor for over 40 years and was the director of the Health District of Northern Larimer County for over 20 years. He has quite a bit of experience both working in medicine and working in community health. So he has a really good experience to share with you guys, because I know many of you are interested in the side of health careers that is very much like nursing and doctors, and I really want you to see how those two sides of health careers can mesh to really serve health in general for individuals and for the community. He graduated with his medical degree from the University of Nebraska, but then later decided to go back to school and get his master's in public health from the University of Northern Colorado. And we are happy to welcome Dr. Bruce Cooper to come and share his experiences with you guys.
Stand where you're standing?
Yes, so if you stand here, you can, the folks joining us can see as well. And I'll go ahead and do this so that you can see them.
That will remind me. So I think it's really cool that you guys are doing this special work and have this special interest in health professions. Any of you already know that you want to apply for medical school and become a physician?
No, you don't want to be nurses, right?
How many on the physician track? Good for you. And I'm sure you've started your work already because good grades are really important, of course, in getting into medical school, but then there's a lot more work. And as you guys know, 4 years of medical school are followed then by 3 to 7 years of kind of specialty training. And my specialty training originally was in family practice, primary care medicine. Hopefully most of you have a primary care doc, maybe it was, or as a pediatrician, perhaps it's a family practitioner. But I wanted to go into family practice because, first of all, you see a wide range of medical concerns, the widest range of any, we call it a specialty, but it's really a generalist that a family practitioner is. You see patients of all ages, and what's really cool about, I thought, about family practice is you follow people over time. You develop long-term relationships with your patients, oftentimes with their families too. And I think that's maybe the richest part of family practice. So medical school, residency at the Mayo Clinic, and then I decided to join a very small primary care practice in Evergreen, Colorado. So a little mountain town just west of Denver, about 30 minutes from the nearest hospital. One other doctor. My team was a nurse I worked with every day, and we had a laboratory technician, x-ray tech, and then some receptionists and people who worked in the back office. So it was a very tiny practice. My day started at 7:30 in the morning. We scheduled patients every 15 minutes from 7:30 to 5. Because of the range of medical conditions and concerns that family practitioners see, there's really no typical day. But the most common things I saw were adults that had chronic medical problems like high blood pressure, cholesterol problems, they had heart disease or diabetes, and were there to get their kind of medications adjusted and helping them change their lifestyles and behaviors, hopefully, so they could reduce their risk of serious disease in the future. We did well woman exams and well child exams and gave immunizations to everybody. Upper respiratory tract infections, colds and flu and sore throats were common everyday problems we saw. Headaches and low back pain were common complaints that people came in with. So that was kind of the typical part of primary care. But because we were 30 minutes from Denver, we also had a very small emergency department. And patients would come in with acute injuries or illnesses. They might have a dislocated shoulder from a fall. There were fractures, there were lacerations, fishing hooks in fingers, and people that had belly pain, kids that had high fevers and seemed really, really sick would come into our emergency room. So we'd have to kind of fit those patients in between the scheduled patients and our appointments. And, it was there were times when it was a very stressful and intensive practice. There were other times when routine was the case, and, you might have a patient that didn't show up and you had 15 minutes to kind of spend a little bit more time with the patients that you'd known for years and could chuckle with over a joke or something like that. So it was a range of experiences, but always you had to be on high alert, no matter what, because you did not know if the next patient that came in for that scheduled visit or they had an emergency had a really serious health concern, a life-threatening health concern, or a lot of conditions that are very serious can present as kind of common medical problems and be a medical puzzle, and you're constantly thinking, what could this be? I remember there was one disease that I was just consciously worried about ever seeing a case of, and it was fairly common at the time. It was called acute epiglottitis. And basically, it's an acute infection of the epiglottis, which is this little flap that flops over the esophagus. Little kids got it from a disease that you guys have all been immunized for now, because Haemophilus influenza is now included in all the childhood immunizations. But when I started practice, it wasn't. And the thing about those babies is they come in with a fever, and their moms would say they had a sore throat, and they seemed really sick. But if you actually used a tongue blade to open their mouth and look in their throat, you could possibly trigger an acute obstruction. And right then and there, you would have to do, intubation, CPR. You could have actually caused the child to go into arrest. And there were some clues, some clinical clues that you needed to be aware of. Every child you saw with high fever and sore throat that kind of told you, wait a minute, be really cautious with this patient and don't stick a tongue blade in their mouth. And I ended up seeing a child with that and also an adult with that in my practice. Luckily, it turned out well, but it just shows you how stressful sometimes primary care practice can be. So that was kind of my experience. I did primary care for 14 years in Evergreen. We slowly grew our practice to 4 physicians and a couple of PAs, physician's assistants. And, I think then I started to think about maybe I wanted to make a change occupationally. And one of the reasons was that I had just learned about a new kind of science in primary care, which is called clinical epidemiology. It was the kind of the birth of what is now called evidence-based medicine. It was on one of Samantha's slides, but I don't think you talked about it. I really got excited about the science of epidemiology. I think you guys have talked a little bit about epidemiology, biostatistics, is that right? And I was a little bit frustrated with how ineffective I felt like I was with prevention, with helping patients think about changing lifestyles to, reduce their blood pressure, exercise, eating better, those kinds of things. And I was really intrigued with the power of population-based strategies to change those things. In other words, community health. I think, to be honest, that maybe the root cause of my thinking about changing was I was getting exhausted with just the intensity of primary care practice. Not to scare any of you guys off to raise your hands, but I think my personality probably was maybe better satisfied with the kinds of challenges that you might see in community health. So what I did is, as Samantha said, I went back to University of Colorado and got a master's of science in public health. I did that while I was practicing, kind of half-time. And then I took another residency, a 2-year residency in what's called preventive medicine, and got board certified in preventive medicine, and ended up slowly closing my family practice, or my part of the practice, and then being hired as medical director of the health district in Fort Collins. And what's interesting about my job at the health district is the health district had just been created. And it's kind of weird. It's not a health department. You guys know probably about local health departments that we kind of think as the center of public health practice in communities. Health districts are few and far between. We don't have a health district in Weld County, but in Larimer County, there's a health district that was created when the public hospital was privatized. And the district is supported by property taxes, so it's tax funded. And it was created, in fact, its mission was literally to improve the health of the community. And I was hired as medical director to decide what that meant. What are we going to do? So I'm going to ask you guys, if you got hired to kind of start a community health agency, let's say, to do the kind of work that you just talked about. And goal number one was to identify the most important public health concerns in the community, the ones most amenable to interventions, and then choosing interventions in order to improve the health of the community. How would you go about it? Any ideas? What would you want to know?
I would like to know like the economic status of the community, also like its proximity to like freshly grown food. So like there could be like a very, very big nutrition problem, and lots of people like just don't know because they don't report it if it's rural or urban, so things like that.
That's really, those are really good points. You want some basic information about the challenges people face, particularly environmental and social challenges people face to being able to adopt healthy lifestyles and be able to stay healthy. And you kind of pointed out one of those things is a lack of access to healthy foods. You know, what we call grocery store deserts. What do they call them? Food deserts, I guess. And so, yeah, you want to look up statistics, and there are places you can get statistics on the density of grocery stores in communities relative to their populations, and whether they're underserved populations, people with lower socioeconomic status, incomes, those kinds of things. So yeah, and you want to know the demographics of your community, meaning, what is the percent poverty level? What's the poverty level among children? What are the ethnic and racial disparities with respect to access to care and those kinds of things? How do you get that information? Well, there's some information published on that. And for the information that wasn't published, we designed a large community health survey. And we surveyed a scientific sample of the population, asking them about their access to physical health care, mental health care, dental care, what their health behavior practices were, their lifestyle kinds of things. And we also asked the kinds of questions that would get at socioeconomic status, so we could kind of see correlation. And what we found in our first community health survey, and we did this every 3 years because we know just as individuals' health change, so do communities' health. What we found was there was, not surprisingly, lack of access to just basic health care, mental health care, and dental care in particular for lower income groups. And this is way before the Affordable Care Act and those kinds of things. So very high uninsurance rates, and people weren't getting the care they needed. We also saw lack of preventive services for certain people, particularly immunizations for children and flu shots for adults. So the interventions that we chose, actually, I love Stephanie's slide about that kind of the ecological approach to thinking about health interventions. I have to admit, we ended up being kind of on the low side. You want community health to be on the top side, or at least have a spread of services across all of those concentric circles. But we had a lot of programs that we started that delivered personal services to individuals, the lowest level, kind of level I delivered as a primary care provider. But they were focused on target populations, and most of those services were developed in collaboration with other organizations in the community. So we did kind of practice community health in that way. One of the things we did was, and we did it in part because there was a little group that just started, a little tiny health van, little mobile health van that went around to neighborhoods in the community that were underserved. And they appealed to us to take it over and grow the program. So in part, that's why we chose that, to address the primary care access issue. And as Samantha pointed out, evaluation is one of the key elements of community health. So we evaluated that program after about 3 years, and we had measurable objectives. One of them was to address what we thought was one access problem to primary care, which was lack of transportation. That's why the mobile van went from one you know, trailer park to the next, and in lower income communities and up into the mountains and rural areas, kind of to address that transportation issue. The other goal of that program was to get people into real primary care, you know, by referring them to primary care physicians that would see them for lower cost in the community. And our evaluation showed that there was no correlation or very little correlation between where people lived and where the health van was parked when they got care. In other words, transportation was not their issue. It was more other things, maybe being able to get off work, having a convenient time where they could take the kids to somebody that could care for the kids while they got their care in the health van. The other thing we found is once they got established with that doctor on the health van, they didn't want to change. They didn't want to go to that primary care practice across town. So we ended up moving to organize a group of other agencies and the hospital, and got a grant from the federal government, and we created a community health center, a federally qualified community health center. And now, luckily, we have them all over, including both Larimer and Weld County. And they provide affordable health care, oftentimes to people without insurance or people who are lower socioeconomic status. And we closed the health van. And that's an example where maybe we didn't dive deep enough to ask the question why, when we were looking at interventions to address this need for access to healthcare. So there are many more examples over our first few years of programs we created and evaluated. Some of them we abandoned, some of them the health district is still delivering. But we created an immunization registry for childhood immunizations because we thought parents needed information and reminders on whether or not their kids needed vaccine. We had mass vaccination clinics for adults in the community every fall. Later on, when mental health and substance use problems seemed to be growing, and primary care physicians were saying, we are overwhelmed with this problem with mental health care in our communities. I hired a staff of psychiatrists, psychologists, and therapists that we then embedded in primary care, our 2 community health centers in Fort Collins. And those therapists work shoulder to shoulder and side by side with the primary care docs in order to address what was estimated to be 50% of their patients with serious mental illness or substance abuse problems. So, you know, that was a successful program that's grown since then. And you see integrated primary care, it's called integrated mental health and primary care in most community health centers now. So I can talk about the emerging changes in our community health over time that made us have to adjust our programs and those kinds of things. But you know, I think what I really want to say is ultimately the health district, the medical director of the health district, me, and the staff I worked with learned a lot in trying to adopt community health strategies and then evaluating them that caused us to, I think, get better over time, so that now we are delivering an array of services that probably is higher on the ecological intervention curve than when we started. And you know, when I think about my job, my job in primary care was absolutely rewarding, amazing in so many ways. Diagnostic breakthrough of appreciative patients, really being able to make a difference in people's lives about things they were very concerned about, but on the other hand, very stressful. Community health was different in many ways. My patient was not the individual walking into my office. It was a community of 150,000 people. My team was not a nurse. My team was this team of 100 people, including everything from policy analysts and epidemiologists to community health workers and program directors. I spent my day not seeing patients, but going to meetings and sitting in front of the computer for many hours doing analyses and writing plans, meeting with community leaders, those kinds of things. So very dramatic and different in terms of what a medical director in community health does. In terms of the impact, it's hard to know whether I made a bigger difference in health in clinical practice or in community health. But one challenge about prevention in general, and certainly community health, is you only have indirect evidence of whose lives you saved, whose lives you made better. And it's mostly statistical evidence, but I have the gut level feeling that my impact was greater in community health than it was in primary care. Both very rewarding experiences. So, do you guys have any questions about either primary care or community health?
Which one did you like better?
Pardon?
Which one did you like enjoy more?
You know, it's an interesting question. I'm not sure I can answer it. I can tell you that I really, really missed my patients and my relationships with my patients when I had moved away from primary care. I actually did primary care on that health fan for 3 years when I went into community health. But other than that, I think that was the real thing I missed. I didn't miss the stress. The stress of always being on high alert for those patients that may walk in the door in primary care was replaced by the stressors I had in community health. Was talking to newspaper journalists, speaking to decision makers on city council or county commissioners or the legislature, public speaking. I don't like public speaking. So those are my stressors, totally manageable stresses. And in that way, I think I liked community health better. I think you have more of a contact in primary care and kind of a feeling, immediate gratification of helping people. That was a real reward in primary care. You don't so much get that in community health. You get your satisfaction from a positive evaluation. So that I think is how I size it up for myself. I'm glad I had an opportunity to do 2 different jobs in my life.
We have a question in the chat that asked, how does your experience as a primary care physician translate to community health planning?
Wow. That is really a great question. It helps to have a background in just health promotion, which a primary practitioner gets, although focused on the individual level. It helps to have an appreciation of the myriad health conditions that people are challenged with, and to have an appreciation of how the healthcare system works. Because ultimately, if prevention doesn't succeed at the community level, people end up needing care. But honestly, there were many weeks when I wondered why I ever went to medical school when I was in community health. And I think had I just started with my master's of science in public health, like Samantha, have you completed it yet?
I have not, I'm close.
Awesome. And honestly, I have to tell you guys that I studied just as hard and was just as challenged getting a master's of science in public health as I was taking medical school classes. So I think, there are so many different professions that contribute to public health work. Everything from community health workers with just a high school education who are doing amazing work out in the community, you know, to people with MD, PhDs that are the epidemiologists, doing the research in public health. So many opportunities in community health. I didn't imagine all the jobs that I might have been interested had I learned about them before I ever went to medical school. But medical school is also a very rich experience.
All right, well, let's take one last question. There's another one in the chat that said, what are the most important skills that you learned through both experiences?
Ooh. You know, certainly the skill of reading the room, they say in other industries, kind of the skill of reading nonverbal clues. You know, having, I don't know if they call it social intelligence or empathy or sensitivity was really important in family practice, because mental health issues were very common, one of the most common conditions out there. But patients didn't usually come in complaining of depression or anxiety. Usually saw it on their faces. There was some other concern they had. It was, you know, I'm tired all the time, you know, or I have this low back pain, headaches, and you know, detecting and then using probing questions to kind of open those patients up to what their experiences were, I think was really important skill for me. And, you know, I think you can learn that skill, but some of it comes naturally on the primary care side. On the public health side, I think, because of my particular role in public health, I love numbers, and I love computers. You know, I think tying those two things together in terms of creating hypotheses and then testing them with epidemiologic tools was a skill that was important to me, and probably was the interest that drove me in, one of the interests that drove me into community health in the first place. But you know, so kind of analytical skills in community health, either way I'd answer that.
Thank you, Dr. Cooper,
Sure.
for speaking with us.
Thank you.
I get to talk to him all the time. I feel like I learned so much. So thank you. Every conversation I learned something new. All right. So we're gonna go ahead and conclude our class this evening with an opportunity for you guys to do some application of your own. So everyone should have received the worksheet. There's two sides. It should be the iceberg exercise and the SMART goals exercise. So once again, we're going to split into groups. Let's go ahead and do the same groups that we did when we did the Safe Teens flyer. And I want you guys to identify a need that you've seen in your own communities. Right? This might be where you live. This might be where you go to school. But I want you guys to talk about a need that you've recognized, and then brainstorm some SMART goals, things that you could do yourself or with a group of friends or community members to make a change with that. Right? I want you guys to think about some of the things that we've learned throughout the year. We've talked about the opioid epidemic. We've talked about nutrition and mental health and all these amazing topics, right? So I want you to really dig into what we've learned this semester and think about things that you guys can do, because even as teenagers, even as high school students, you guys have a voice and you guys have power to make a difference in your community and be advocates for the health, for your own health and for the health of those around you. So I want this to be something that you guys are passionate about, okay? Does anyone have any questions about the goal of this activity? All right, if there's no questions, I'll go ahead and let you guys get started. Matt, can you break out the online kids in the breakout rooms?
Yep, I'm sending them right now.
All right, and definitely, I encourage you guys to make use of the leaders in your room, your teachers or your AHEC members, and use your technology. If you need to look something up for an idea that you have, get on the phone, get on a laptop, do your research. This is all about you guys, all right?
Alrighty, Samantha, are you guys wrapping up out there? I can't see you.
Guys. Oh.
Okay, everybody, I'm going to go ahead and share a couple things with you. Is that okay with you, Sam? All right. I want to say thank you to Sam, to Samantha, and Dr. Cooper if you're still there. I am going to... Oh, I thought I could share screen. I'm sorry. There we go. Okay. All right, so first off, guys, I want to share that registration for Hope Institute is officially open. I can see a few of you guys. Raise your hand if you got an email from me recently with that information. So Greeley got it. They're the only ones I can really see. So I'm glad you guys got it. If you did not get the email, I'm going to give you guys a QR code here. You can snap that. We're also going to need to do a survey here in a minute. So go ahead and snap that and maybe put it on a different different tab and just hold it for later. But this can be a registration code for any of you who did not get the
Matt, the QR code is cut off.
Uh-oh, okay.
You will scroll more.
Does that work?
Perfect.
Okay. So if any of you guys need the QR code, it's right there. You can also email your Hope coordinator, and they can get you the QR code, or they get you the registration code. But a few details I want to make sure everybody knows. We are going to do a week-long camp, July 10 to July 16. We're going to stay at the University of Colorado, Colorado Springs, where they've got really cool facilities where we can do some simulation activities, cadaver lab, work in the culinary lab, so all sorts of different ways that we can explore health careers. That's also where a lot of the Olympic athletes go for healthcare, especially related to exercise and sports performance. So we're going to get to play in their sports performance exercise science labs as well. And this is totally free. We're going to have buses that are available for students to come from all over the state. So you guys don't need to worry about transportation either. And it's going to be an awesome time. I'm really looking forward to it. So, and the good news is if you completed 3 sessions of Hope program, then you get primary or priority status when we are accepting students into this program. So you guys are first on our list to get to be a part of this Hope Institute. I am going to switch over to the survey now. But then if you guys have questions, you can stay on afterwards and either ask me or talk to the folks in your in the office where you're hanging out. Sorry, real quick. I thought I had this survey up. Okay. And then if you would also just take a quick snap of this survey and let us know what you thought of tonight, just like we've been doing every other night. And as you're doing that, I just want to say thank you to all of you for putting in so much effort and time and energy. Do you guys see the QR code or the Hope logo?
They weren't able to scan it. It was not up long enough.
That's the wrong one. Okay, that's not what I meant to have up. I'm sorry, guys. Little technical difficulty. There we go. Oh, you know what? I probably clicked some funny button to have it scroll through like a slideshow. Okay. Is that working now? I see it on Alexis's, or Stephanie's got the number. So thank you all for being a part of Hope Hope program. And I do hope that you come to Hope Institute. But also thank you so much for all the effort you put in. And especially thank you to all the Hope Institute or Hope program coordinators and any of the other adults who are volunteering their time or contributing their time and talent to make this happen. So thank you all very, very much. I look forward to meeting you in person at Hope Institute this summer. And like I said, if you want to hang out and ask questions about Hope Institute or just any questions of me or your leaders, no hurry in getting out of here. But that's all I've got for tonight. Good night, everybody.